On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
Yes, thank you. Well, what I'm going to share with you this morning is the results of the first human prospective trial in popliteal artery lesion, comparing treatment with balloon angioplasty, which is considered as the gold standard, compared to nitinol stenting. Don't know what I need this disclosure slide here. It was added.
10 seconds always.
Okay, good.
No matter where you go.
Well, so the background of this trial is that the popliteal artery is considered as a no-stent zone due to potential excessive external forces applied to the stent in the popliteal fossa when bending the knee. No prospective comparative controlled trials have yet investigated the performance of stents in the popliteal artery to date. The ETAP trial is the first trial comparing primary stenting using a contemporary nitinol stent device, the live stent, which is approved for SFA application in the US, with the current gold standard balloon angioplasty. It's an investigator-initiated European prospective randomized controlled multicenter trial, including 9 centers. We secondarily, after starting the trial, received an unrestricted grant by BART Angiomate. We have independent data management and core lab adjudication. It's a one-to-one randomization between balloon angioplasty and with provisional stenting versus primary stenting using the live stent, as already mentioned, and the patient cohort comprises about 246 patients suffering from Rutherford category POD 1 to 4. That includes breast pain, but no CLI patients with non-healing wounds. There had been no restrictions in terms of lesion length. What you can see over here, that's the lesion characteristics. Lesion length was pretty short, in average somewhat more than 4 centimeters, without a difference between both treatment cohorts. About 1/3 of the patients had been treated with chronic total occlusions, and mean diameter stenosis was not different between the 2 cohorts. And this is the primary endpoint. This is primary patency at 1 year, diagnosed by duplex ultrasound. Definition of patency was a peak systolic velocity ratio of less than 2.4, and the difference between both cohorts was clearly in favor for primary stenting. These are the clinical outcomes at 1 year follow-up. Overall, there was no difference in terms of death, major or minor amputation. TLR rate had been in favor for the stent cohort in an intention to treat analysis. That means that a PTA failure was calculated and counted as a TLR as it was done already in the Resilient trial and in the Silver PTX trials. If you look only on the outcome of TLR in an on-treatment analysis, meaning following the procedure, so if we analyze the days after discharge to 1 year, then we see only a slight trend towards a better outcome for the stent cohort. Limb salvage rate, well, in line with major and minor amputation rates, no difference. Change in ABI, this includes every time redo procedure, so it's not surprising that this difference is not significant. Same holds true for the median change in Rutherford category. However, there was a significant difference in the change in absolute walking distance in favor for the stent cohort. So in summary, ETAP is the first controlled trial investigating the performance of plain old balloon angioplasty with primary stenting using the live stent in the popliteal artery. Live stent placement in the popliteal artery has been shown to be safe. What I did not yet show is the core lab adjudicated fracture rate of 3.4%, which is in line with the data presented for the same stent device in the SFA. Live stent placement results in a significant higher primary patency rate as compared to POBA. In intention to treat analysis, no significant difference in change of Rutherford categories was found. However, there was a significant better improvement in absolute walking distance. I thank you for your attention.
Thank you, Professor Zeller, for that wonderful, short, and perfect presentation. Anyone have any questions from the press, please?
Just to make sure this was not a drug-eluting stent.
No, it's a bare metal nitinol stent.
Hi, Ed Sussman with MedPage Today. Dr. Zeller, how long have you, I realize this is a one-year study, but how long have some of your patients been using this stent, and does it continue to have positive results?
Well, the patients are still undergoing the 2-year follow-up, so we have not the final data set for that, and the primary endpoint was defined as the 1-year outcome. So we will have the patients, or we will get them back up to 3 years.
Any other questions? To Linda?
Are you planning another study using, instead of plain balloon valvuloplasty, a coated balloon, drug-coated balloon for popliteal artery disease?
Well, currently not. What we are looking for is a trial looking on the performance of drug-eluting balloons in this area. Even if it has been shown that stent fractures are of minor concern, the 2 fractures we found had been type 1 and 2, that means single stent fractures, so nothing severe. Even if stenting is safe in this area, we are still looking for a stentless approach.
Yeah, I think that's really crucial, especially for the press, to understand the popliteal artery is the artery right behind your knee, so bending all the time. And so you'd expect, maybe, do you think you're going to get more fractures down the line?
Yeah, well, this is definitely not true. And what has to be considered is, in particular in the mid-segment and distal part of the popliteal artery, the compression forces are less than, for example, in the femoral-popliteal conjunction. So,
that's right.
And for in particular for this area, the live stent is approved in the US. Mm-hmm. It's approved for SFA and proximal popliteal application.
Great. Question?
Quick question. What is the crossover rate or the bailout stenting rate in the PTA arm?
It was about 24%. So that means that in those 24%, you need to put in a stent, otherwise you will not end with a perfect angioplasty result.
Any last comments? Yes, please.
Yes, Ed Sussman again. What was the, did you have any cases in which you could not get a stent in place?
No. If you can get a wire through a lesion, you can also place a stent. So there's no way. Yes, okay. Getting through a lesion with a wire is the crucial point. Putting in a stent is not.
Dr. Faxon, you're going to close this session.
Just a very quick question. How did you manage the restenosis in the 2 groups?
Well, basically, we are in Europe. We have the lucky situation having drug-eluting balloons available. So our most likely approach is to use drug-eluting balloons in instant restenotic lesions. Otherwise, you can simply balloon, considering the relatively short mean lesion length. So in short lesions, plain balloon angioplasty is the first-line strategy. If this fails, then we go to some kind of drug-eluting technology like drug-eluting balloon or stent.
Thank you very much, and I want to take this opportunity to actually congratulate our investigators for an amazing session with great trials, and thank them for choosing to present them at this premier interventional meeting. And I want to thank Irma Domhais, who's done an incredible job with this, and all of you for being here and having interest in our field and wanting to have a very positive impact on your reporting to the world. And thank you, our discussants, and we'll see you all tomorrow again at 9 a.m. for our next press conference. Thank you again. Bye-bye.